My name is Nieuwboer and I'm a professor in rehabilitation sciences at the University of Leuven in Belgium. I was asked to talk about which clinical factors explain freezing of gait. Now, Dr. Nonnekes already showed that freezing of gait is a multifaceted gait interruption. And what I will do in this talk is go deeper into some of these motor and non-motor factors that are associated with freezing of gait. First of all, I want to go back to one of his questions. Do freezing subtypes really exist? And at the moment we're unsure. But certainly this particular study looked at in which situations patients reported that their freezing was most frequent. And in blue, you see here one cluster that said that they had more freezing when they were making turns, and these patients also had more motor asymmetry. In green, you see a cluster of people that reported to be particularly sensitive to distraction and therefore had cognitive fog, and they also had more problems with set shifting. And finally, there was also an anxiety group that were reporting their problems with stress as a factor that brought on freezing of gait. And also these patients had higher levels of anxiety. Now, what we also could see in these results, that people with set shifting and anxiety fog also had higher levels of disease progression. So therefore, it is possible that patients start with having motor fog only, and then slowly progress into having multiple factors that bring on freezing of gait. And for that, of course, we need longitudinal study. Most of all, I think we need to see whether subtypes really exist when freezing expresses itself in behavior. This is a study which is the DFOG study, which we do together with our colleagues in Tel Aviv, whereby we're looking at freezing patterns in the home, in on and off, during 5 triggers, as you can see them displayed here. And we calculate the percentage time frozen. Now I'm going to zoom into 2 of those triggers. On the left here, you see a patient that starts to freeze during a 360-degree fast turn to the right and the left. And although it is not a very functional task, it is very sensitive and reliably so for freezing of gait, as you can see. However, this lady can do this task perfectly without any interruption and without any freezing of gait. And when we asked her where in the house she freezes most, she could take us to this pantry, and we call this the hot spot of patients. And we consistently, during the protocol, bring them to these freezing hotspot. And you see reliably, this is where she does freeze. Now, when we look at the results so far of the 29 patients that had gone through this protocol, both in on and off red and in on green, we see in the middle of this graph that the highest prevalence and percentage time frozen was found in the fast 360-degree turn task. And what is also very striking for us was to see that between on and off, there were no significant differences, whereas in the other freezing triggers, there were clear levodopa responses. So this will bring us more and better data, I think, of where freezing really occurs, namely in the home situation, although this is still in a standardized protocol. Now I want to move to talk a little bit about the subtype of affective freezing provoked by anxiety. And this paper in 2014 compared patients' walking pattern over ground in a virtual reality or in the elevated condition on the right-hand side, whereby patients had the feeling that they were walking over a raised height. And that induced fear of falling. And in the fearful condition, patients had more freezing of gait episodes, and also heart rate changes were recorded, particularly in the anxious type of freezing. Now, this fear of falling and in analogy, fear of freezing may also increase the episodes. And that may be the explanation, or one of the explanations, why patients tend to freeze in their hotspot when they are anticipating on a freeze and starting to experience stress. However, when we look at this recent paper, we see that the heart rate changes, which can be seen as a proxy measure of anxiety, we see that the raising of heart rate changes particularly occurs in the anxious type of freezers just before the freezing onset. And this was not the case in asymmetric freezing and cognitive freezing. So that shows us the relevance of looking at different triggers and different subtypes even more in the future. I want to spend a little bit of words too to the subtype of cognitive freezing. From many studies, we could already gather that patients with freezing have more reduced cognitive capacity when we compare them with non-freezers. However, disease severity is an important confounder, and when you control for that, these differences are not so clear any longer. We can still think and project and speculate that the decline in cognitive function above a certain threshold may actually make patients more amenable to freezing when they're not able to be resilient to distraction any longer. Now, also stress when approaching a freezing-provoking corner probably also induces an attentional bias towards the threatening stimuli rather than trying to induce a rescue response. And this points to the interesting and possible synergy between non-motor symptoms and their role in increasing the freezing severity. And this is, of course, subject for further investigation. Now, all freezing research stands or falls with measures of this interesting phenomenon, and I already showed how difficult it is to measure it accurately. So many groups around the world are using artificial intelligence to measure freezing of gait by using variable sensor signals. We are also developing a method like that in our lab. And here I'm showing some results of a comparison between an artificial intelligence algorithm that we built and used deep learning for, based on gait laboratory signals that we picked up in our three-dimensional gait lab. And we compared that with an expert that based freezing annotations on video recordings. So you see there are quite some discrepancies in the pink and the green colors, and this is already indicated by the expert as freezing. And within that full and disturbed turn by a freezing phenomenon, you see that the algorithm actually detected smaller and more specific freezing episodes. So this method, I think, is promising. And of course, we also want to bring this particular algorithm now to being able to calculate sensor signals from several resources, also from anxiety signals. And then finally, our aim is to bring this method in a reduced format to the home situation, where, of course, it is our ultimate aim to measure freezing accurately. Finally, I would like to talk a little bit about the relationship between freezing and balance problems, and particularly how that relationship may come about, because we know that 61% of fall incidents are related to freezing of gait. And therefore, we recently did this experiment that we're about to publish, in which we asked 3 groups to perform weight shifting movements from right to left in relation to the white ball that is projected on the screen, which goes from right to left in a faster and faster fashion. And you see here that patients with freezing have a much reduced amplitude during their task. And we found that the invigoration of that movement and the adaptation of this very actual movement is reduced in Parkinson's disease, and also more in off than in on. Now, this has clinical relevance because the group of Will Young also showed recently that when you compared freezers and non-freezers at baseline, when they're making medial lateral weight shift, that indeed freezers were much reduced as well. But what they showed is that with a verbal instruction to control the weight shifting, freezers were able to correct this pattern of movement. And more importantly, as a result of that improved weight shifting, they were much more often successful in stepping away from a freezing episode. And that is a principle that we're also using in the DFOG study that I already mentioned, whereby we're using wearable sensors on the shoes and on the chest to perform online gait analysis in the home situation. And that allows us to do immediate fog detection when it happens. And also at that very moment, we can then provide patients via earphones with a cue or an instruction to improve their weight shift to help them to ameliorate these episodes in the home situation. These results at the moment are being collected at the moment. So finally then, I would like to conclude that the heterogeneity of freezing episodes are very important to understand to be able to design personalized treatments. I also believe that we need to increase the resilience of freezers in both motor and non-motor domains to improve freezing of gait. And finally, we really need to solve the bottleneck of finding sensitive freezing outcomes to detect subtle and early freezing, and that allows us to start treatment early as well. Thank you very much for your attention. Nou, dat